Thank you very much for the opportunity to talk about the concept study. It's been over 5 years ago now since we conceived a randomized controlled trial, which is a UK-based multi-center study. I'm Sheng Professor of glaucoma studies at St Thomas's Hospital and also King's College London. And these are my co-author for the particular study. Tom Sherman is the research fellow who pretty much run the study. These are my financial declaration. And now, what is interesting about FRCOphth ECP is that despite its approval over 30 years ago now, there has been not a single randomized controlled trial for the use of ECP in primary open-angle glaucoma. And that has been picked up by a Cochrane review recently, saying that really we need high quality RCT to support the usage of ECP in a normal clinical practice. This is the reason why concept really was created, trying to fill the gaps in the literature about using ECP in primary open-angle glaucoma in conjunction with cataract surgery. So now, ECP essentially, you can look at it as a mixed procedure with our device placement. I would say most commonly, or 99.9% of the time, is really performed in conjunction with cataract surgery for mild to moderate cases of glaucoma. And the beauty of it in some way is that you can titrate the treatment. You can treat 180 degree of the ciliary body, you can do 360, depending on the severity of the disease. Now, certainly the idea of treating the inflow is not new, reducing aqueous production. We use that quite commonly in using glaucoma drops to reduce the aqueous production rate. So the ECP essentially target that inflow pathway and reduce the IOP production, or reduce the IOP level rather. So what you need is a light source and an imaging system and a dye laser delivering system to treat the ciliary body. What is, again, the nice thing about it, not just titratable in terms of area they can treat, but you can look at the reaction of the ECP dye laser as it delivered to the ciliary body epithelium to guide you what sort of power you need to elicit ciliary epithelium reaction. So, and also, in a way, you're targeting the treatment to the tissue that you want to treat rather than a transscleral dye laser, which is a slightly blind way of treating ciliary body. And in fact, ciliary epithelium really is the only tissue we really want to treat in this case. Now, this is a video of a animation, as I say, of FRCOphth ECP. Now, we tend to like to do ECP only after a uncomplicated cataract surgery, and the idea is that once you've done the cataract surgery, the anterior chamber is much deeper, and also you're not going to be able to damage the lens tissue. So what you need to do once you've done the cataract surgery is inflate the sulcus space using viscoelastic. You can use heavy GV, or you can use just normal Provis or Helon. It's absolutely fine. I don't think it matters which one you use. Now, there are two types of endoscope, a straight one or curved one. Personally, my preference is to the curve, using the curved one, because I think you can treat a larger area of ciliary body by using a single probe or sitting in one position. And you can see as you start with a low level of laser energy, and you can increase it slowly until you see that reaction. And this is what you see in the video of the live treatment. You can see the dye laser being delivered to the ciliary body. You can see the whitening of the ciliary epithelium, and essentially you're cauterizing the ciliary epithelium. So this gives you the direct evidence of the tissue that you are treating, unlike transcaral dialaser delivery. As I say, you can treat 90 degree. I think 90 degree is probably too little, but I think most people do a minimum 180 degrees of the body. And if you want to do that, you have to come from a second position to do the rest of the cerebroepithelium. If you look at long-term data of FRCOECP from other types of study, non-randomized study, there's been quite impressive IOP reduction long-term using combined FRCOECP. So what is interesting is that the concept study, when it was created, we were targeting only the earlier moderate glaucoma because we had to wash out the patient to get a pure effect of the procedure. So this is unlike the initial indications of ECP, which is really only for severe glaucoma. So hoping to provide some more evidence for early to moderate glaucoma, primary oblongo glaucoma with cataract having ECP laser. So the patient will wash out at pre-op and had the surgical treatment, 12-month washout and 24 months washout. We did one stratification, which is the IOP level, because we do not want one particular arm of study having a much higher IOP level compared to the second arm. Based on the power calculation that we have done, we needed about 80 patients in each arm of a 1-to-1 randomization of FRCO or FRCOECP after uncomplicated cataract surgery. Now, it is important to stress that the patient did not know whether they had ECP or no ECP because we did a sham treatment for those eye who had been randomized to just FRCO surgery alone, that would pretend to be doing ECP, but we didn't actually do ECP. And the person who does the measurement of IOP did not know which arm of the patient were randomized to. And beyond that, the follow-up periods are standard in terms of FRCOECP, what you would normally do in a standard clinical practice. So this is what we are seeing here. And in terms of the number and the baseline characteristic of patient. So in the ECP arm, we have 79 patients, and the FRCO alone arm, we had 83 patients. So pretty much 1-to-1 randomization. Now, ethnicity is always an issue. Interesting aspect of study coming out of London is that we have a huge proportions of Afro-Caribbean patients in the South London area where St. Thomas's Hospital is. So invariably, our population for any study tend to derive hugely from these groups of patients. As you can see, it's pretty much a 50-50 distribution in terms of Caucasian and Black or Afro-Caribbean population. And if you can see, the mean IOP post-washout is exactly the same, 25 in each arm, roughly. And the mean number of medication, again, is 1.8. Don't forget, we did stratification at IOP, so we weren't hoping to see any difference between the two anyway. And so really, there isn't any difference between the two arms. And the mean deviation in terms of visual field confirmed that this is really in groups of early and moderate glaucoma. So, as I said earlier, 1-to-1 randomization, about equal number in ECP and equal number in no ECP. What we have is data from about 140 patients for various reasons. There will be DNAs for any clinical trial. Some would have glaucoma surgery prior to the 1-year washout. And some, for clinical reason, they're unable to undergo washout. So those were taken out. And they're from both arms, although a bit more from the FRCOECP arm. And again, as I say earlier, the washout IOP, the very similar, about 25 millimeter mercury in both arms. And you can see this IOP drops at 1 year. In the FRCO arm, went from 24 to 18, and the ECP arm went from 25 to 19. So it's about the same, but you do see that FRCOECP arm has slightly greater in terms of the IOP reduction. So the mean change in IOP, as you can see, the FRCOECP arm is 6.52 millimeter mercury versus FRCO alone, which is 5.62. So you gain about a millimeter mercury adding the ECP laser. And this is the distributions of the IOP. It can be complicated. Essentially, vast majority of the patient's pressure went down after the cataract surgery or cataract surgery combined with ECP laser. Only very few end up having higher pressure than baseline, which is below the red line after at 1 year washout. And now, when you look at the data, it's always difficult to decide whether you analyze using the mean or the median. In general, people say if you have a normal distribution curve, you should use the mean IOP. But when we look at our data, it actually looks like a non-normal distributions of IOP. So we decided to look at the median IOP. And the median IOP, you can see the post-surgery was 19 in the FRCO arm and 17.5 in the FRCOECP arm. So there were 1.5 millimeter mercury difference in the two arms in terms of IOP at washout, I must add, at 1 year. So if we look at success rate, again, you consistently see that FRCO with the ECP appear to give you about another 10% greater success rate. So if you have IOP is 18 or 20% and 20% reduction, you can see the 46% success rate versus 36% in the FRCO alone. And if you set the bar a bit higher of 21, again, you still see about 57% success rate versus 49% in the FRCO arm alone. So it appears to show us consistently that FRCO with ECP provides a better IOP control at every level of IOP when you set it as a success criteria. Number of medications, as you can see, 1.7 as standard, down to about 1 at 1 year. Very similar in both arms. So there was quite a lot of reduction in IOP level. There is what you expect in cataract surgery, the improvement in visions. You can see at 12 months because most of these patients had cataract surgery at the same time. So we weren't really expect to see anything different at all. The other thing we were looking at was the refractive target, whether once you apply ECP, do you achieve less accurate refractive target? But it doesn't appear to be the case at all, whether you do ECP or not. You seem to get very accurate predictions of refractive outcome in reusing ECP. So in summary, I think it's an exciting time. In concept is the first randomized controlled trial comparing cataract surgery alone versus cataract surgery with ECP laser. And these are all in early to moderate primary open-angle glaucoma patient. There's an equal split between Caucasians and Afro-Caribbean patients. So I think it's quite interesting to see the subgroup, whether there is actually difference between the success groups, success rate in the different racial groups that we see here. So far, the data hasn't been fully analyzed because we still have some data missing, but it appears to show that the IOP reduction is about 1 to 1.5 millimeter mercury more than FRCO alone. And in terms of percentage success, you're seeing about added 10% in success rate in most of the cutoff point in terms of IOP success, either 18 or 21, using ECP versus just cataract surgery alone. Thank you very much.